Hi guys, and welcome back to the channel. If you are new here, hi, my name is Brittany. I'm a nurse practitioner. I'm also the creator of the Brittany Holzbeck NP Review. It is the most affordable and comprehensive nurse practitioner boards review on the market. It is accredited through the AANP, so if you take the course, you can receive a little over 17 continuing education credits. And this means that nurses, nursing students, nurse practitioner students, even licensed nurse practitioners can actually go ahead and take the course if you would like to collect continuing education credits. So everybody can take it. Even if you're not going to take your boards exam, it's a great refresher and it's just a really great learning resource. So my entire course is available on Patreon. There are different tiers available on my Patreon, so make sure that you read each one closely so you know what you're purchasing before doing so. Everything you need will be linked in the description box below if you want to go ahead and check it out. If you have any questions, let me know. So in this video, I'm going to be going over the management of burns in the outpatient setting. So for a quick refresher on how the severity of burns are classified, I'm sure we've all seen this, rule of nines, which gives us an estimate of the total body surface area that is affected by the burn. This is a very important tool for you to reference when you're examining your patient with a burn, to determine how much of their body is actually affected. Also, though, it's really imperative that we determine the depth of a burn and whether it's superficial, a partial burn, or a full thickness burn. So a sunburn, this is generally an example of what we call a superficial burn. So these types of burns are dry, red, they do not blister, and they easily blanch. These type of burns can be painful sometimes. It's important to note though that superficial burns, they are not counted when we're calculating on that total burn surface area. So we don't even use that when we're doing the rule of nines if it's a superficial burn. Now, superficial partial thickness burns, these are a little bit more deeper burns. So they're typically moist, red, they do blanch, they're often very painful, and these types of burns, like I said, are counted when we're calculating the total burn surface area. And then after that, even deeper are the deep partial thickness burns. These are drier, they appear more pale, they are less blanching and generally less painful because they are starting to lose sensation now that they're getting this deep of burns. And these are also counted when we're calculating the total burn surface area. And then finally, the full thickness burns. These are dry, leather-like in its texture. They can appear a couple different colors, so they can look white, brown, or black, and there is a loss of sensation here. And of course, these are going to be counted when we're calculating our total burn surface area. So generally, partial thickness burns that are small in size, non-circumferential, and without concern for any kind of inhalation injury or a high voltage injury, these typically do not require surgical management, and they can typically be managed outpatient. However, oftentimes a consult with a burn specialist is still going to be warranted. So I found a really helpful tool. So the American Burn Association, they provide very user-friendly guidelines on when to consult a burn specialist and when an immediate transfer to a burn center is warranted. And I have the link here on this page, so you can definitely check it out for yourself. I recommend that you do, but I also want to go over with you just quickly here. All right, so as you can see, this again is titled The Guidelines for Burn Patient Referral. This is from the American Burn Association, and this is to help guide you on what you're going to do with your patient. So on the graph there's two columns. There's the immediate consultation with consideration for transfer, and then the other column is consultation recommendation. So full thickness burns, partial thickness burns that are 10% or greater of the body, any deep, partial, or full thickness burns involving the face, hands, genitalia, feet, perineum, or over any joints, patient that have burns and other comorbidities, patient with concomitant traumatic injuries, poorly controlled pain. All of those are recommended for an immediate consultation with consideration for transferring to a burn unit. Also, any patients that have a suspected inhalation injury. All pediatric burns, generally they recommend could benefit from a burn center referral due again to pain management, dressing changes, rehabilitation, patient and caregiver needs, or non-accidental trauma. All chemical injuries, all high voltage electrical injuries, and a lightning injury, all of those, like I said, those are recommended for an immediate consultation and considering for transfer. So, and then in the other column where they talk about recommendation for consultation, any partial thickness burns that are less than 10% of the total body surface area, all potentially deep burns of any size, patients that have signs of potential inhalation, so facial flash burns, singed facial hairs, smoke exposure, and then also low voltage electrical injuries as well. So all of those still, they recommend that you do consult. If you actually go to the website where I have the link there, there is a like a pop-up where it helps you find your local burn centers. So it's really, like I said, user friendly. And then here on this slide too, on their PDF here, it talks about again like burn severity determination. It talks about the rule of nines again. So it's really a useful tool if you do have a patient with a burn. Okay, so generally though, a good rule of thumb is that if you are ever unsure, it's just best practice to err on the side of caution when it comes to managing patients that have burns. So consult a specialist. It's a quick phone call, and like I said, best practice is erring on the side of caution. And like I said, if you follow that link, when you get to that the webpage through the American Burn Association, there is a search engine there that'll help you find your local burn center. So really easy if you need a consult. Okay, so let's move on though and say that we've determined that you can manage your patient with a burn safely in the outpatient setting. How should burns be managed? So if a burn does occur, the first step is to remove any clothing, jewelry, any debris from the area and immediately begin cooling for up to 30 minutes. So this can be done with either room temperature to cool tap water, or you can even use cool wet gauze or cool wet towels. And this is done because cooling the burn helps to decrease the likelihood that the burn will increase in its depth. Some experts actually prefer the cooling with the cloths or with the gauze as opposed to running water, because some say that the running water can cause wound maceration to occur, so something just to consider. These are all obviously important education points too for your patient. So, in the unfortunate chance that they experience a burn again in the future, they know what to do. So aside from cooling the burn, cleansing of the wound should also occur, and it should be done so using simply tap water and a mild soap. Also, the wound should be debrided. Any sloughed or necrotic skin should be removed. Also, blisters that have already ruptured. That's an important point though, because we do not want to manually rupture any of the blisters ourselves, because this can increase the risk for infection. So like I said, intact blisters, generally these should be left alone. If the blisters persist now for multiple weeks, then the literature says that the patient should be referred to a burn center for further exploration and to confirm that there's not a worsening underlying burn that's going on. And then as far as antibiotic therapy, so generally superficial burns don't require any kind of antimicrobial. Only a moisturizing cream is going to be recommended. If the burn is a partial or a full thickness burn, a topical antimicrobial is recommended after daily washes with mild soap and water. So the most commonly used antimicrobial is the 1% silver sulfadiazine. This we apply once or twice daily and then cover it with fine mesh gauze. However, it's important to note that this should not be used in patients who are pregnant, breastfeeding, infants less than 2 months, and also should not be used near the eyes, as this is actually considered oculotoxic. So those are just some contraindications that we want to be aware of. Also, if they have a sulfa allergy, then the sulfadiazine is not an appropriate choice as well. If there is a concern for MRSA, then we can use the bacitracin, and this can be added to the treatment plan. Another important point is that if it's determined that the patient is going to be transferred to a burn center, the patient's burns should be dressed in non-stick gauze only with minimal topical ointments. That's very important because once the patient arrives at the burn center, the dressings are immediately removed, and so extensive dressings or extensive ointments only delay the patient's care, and they also can contribute to degradation of the wound. So just really simple non-stick gauze, very minimal anything covering the burns. Also, in regards to pain control, it is preferred that patients with burns who are appropriately managed outpatient be treated with simple analgesics. So, for example, rotating acetaminophen and ibuprofen for continuous pain management, that should be appropriate. And then finally, burn patients, they should have a close follow-up to make sure that they are healing properly. It's recommended that they initially are seen the following day to assess their pain control and their ability of cleaning and dressing their wounds at home. And then once a week visits until the epithelialization occurs. Of course, from an urgent care standpoint, your role is to refer them back to primary care for a next day follow-up. If they don't have a PCP, we want to establish that for them or who they are going to follow up with the next day. So whether you are establishing them a PCP or you're having them return to the urgent care office, your role is just to establish where they're going to go for the following visit. All right, hopefully you guys found that helpful. Let me know in the comments below if you have any questions for me at all. As always, I wish you guys nothing but the best. Don't forget to learn something new every day, and I will talk to you soon. Bye, guys.